Hi, good morning, everyone. Yeah, we have already a few participants joining us, and I think it's a good idea to start on time. So delighted to be here with everyone. Thanks so much for joining us on this session about keeping communities safe and what lessons we have learned as social entrepreneurs and the implications for the current crisis that we're all living through and any implications beyond that. And what we really want to do in this session is we have a wonderful set of experiences here that we have gathered with us, and is to draw on these, reflect on these, and then really look at a call for action, what it is that we could be doing really better than is the case at the moment. Yeah, there are good things happening, no doubt about it, and the announcement this morning or coming through yesterday from the Biden administration about potentially lifting patent protections on COVID vaccination is potentially a bombshell, is really a big development. Let us see if that is able to come through. Nonetheless, despite some progress, we know that indeed it's not simple. In many countries, the ravages are really being felt very strongly. Karina, I think you have a bit of housekeeping for us just to get started. So over to you.
Great, thank you so much. Hello, everyone, and welcome to Catalyzing Change Week. Yes, as you can see on the PowerPoint slides, please keep yourself unmuted unless you want to speak, and preferably keep your camera on. This meeting will be recorded and afterwards be put on our website and on our YouTube channels. So yeah, welcome again. I will slowly but surely switch the slides to an introductory video about Catalyst 2030, and then I will let our wonderful speakers have the floor.
Catalyst 2030 started life as a WhatsApp group among social entrepreneurs, connecting to envision real transformational change. Launched at the World Economic Forum in January 2020, it's grown into a global movement accelerating change to ensure the SDGs are reached by 2030. Fueled by passion, our 550 members working in 175 countries have collectively put in an amazing 50,000 volunteer hours, touching the lives of 2 billion people. And we're driven by values, to which we hold ourselves accountable. 2020 was a busy year, co-creating 3 reports with partners and producing one of our own. Inviting high-level guests to participate in the Catalyzing Change campaign, hosting fireside chats and expert hours, which will be continuing in 2021. To celebrate our achievements, together we placed our supporters in the limelight with the first Catalyst 2030 Awards for Systemic Change. With the blessing of the Dalai Lama, we celebrated finalists and winners in the following categories: special recognition for our early supporters, individual philanthropists, donor organizations, philanthropic intermediaries, corporate organizations, bi- and multilateral organizations, and 4 regional winners in the category of national governments. And now on to Catalyzing Change Week 2021. During this social entrepreneur-led event, we bring together diverse stakeholders in over 100 sessions to showcase their systems change efforts and the best practices that can accelerate our work in pursuit of the SDGs.
A lot is indeed happening in Catalyst 2030. Wonderful to see several friends on the call, and I hope a few more will be joining us. So good morning again, and good evening for some of you. Fredrik Galtung here from TrueFootprint. And maybe the people on the panel, if you can rename yourself and just put your organizational affiliation as well, it helps for the participants on the call to see a bit better who you are. So just a few introductory remarks from me, and then I want to turn it over to our panel. What we're wanting to look at here today is what are the lessons learned from social entrepreneurs working to keep communities safe during the COVID pandemic. Right? We've had this unique moment in our lives of sharing this collective experience, but it hasn't hit all of us in the same way, obviously, right? I'm in Israel at the moment, and I got my 2 vaccinations very early on, as has about 80% of the adult population in this country, right? For all intents and purposes, the pandemic as such, the threat of the pandemic is over in this country, but it's by no means the case elsewhere. Vaccine hesitancy in Israel was extremely low. There were little elements of it, but as I said, 80% of the adult population, and now 16-year-olds, 14-year-olds getting vaccinated as well. Because the US is doing well, the UK has been doing all right. But again, the death rate of COVID has been, again, very unfair and unevenly distributed. So not surprisingly, in a sense, despite all efforts in some countries by all means, but 17,000 healthcare workers have died from COVID infections. Many, many more have been infected. And then there's a hidden number which hasn't been tallied at all, but is of how many healthcare workers have left the profession. Lots of healthcare workers have left the profession over the last years. Doctors, nurses, other professionals. It's thousands upon thousands just in the UK. It's in the low tens of thousands in the US. And those ripple effects will be felt for a long time. We saw early on how certain ethnic groups were harder hit than others. There were great concerns about vaccine hesitancy being greater in certain populations than in others. And there some efforts were made. But for example, the fact that 6 out of 10 people who've died of COVID in the UK are people with disabilities. Some of these people with disabilities are elderly, right? It does hit the elderly much, much harder. The death rate doubles for every 6 years of increase in age above the age of 50. So yes, some of them are elderly, but many of them are not, right? And Shona here, that is very much her life's mission, is working with people with disabilities. I guess the bottom line question here is the following, right? So much emphasis has been placed on the supply side of this pandemic, how to provide personal protective equipment, testing, and eventually vaccines. But what about the demand side? What does it mean to have a people-centered approach to this? And so as TrueFootprint, in partnership with Catalyst 2030, we launched the COVID Care Monitoring Coalition in July last year, reaching out to our networks and within Catalyst 2030. And within just 8 weeks, we had partners in 54 countries, wanting to report from the front line of health services about what is happening, focusing first on COVID safety, then on access to medicines, and then on vaccinations. We were able to show with partners like Sipho Mwanza here, and I see others on the call like Michael Yola, that indeed tremendous things could be done on the ground. And we will hear from our other friends here on the call what they are doing. And yet we found it very hard, right, in terms of engaging major public health agencies and bodies in what can be done to have, again, this more people-centered approach. It's not that the resources aren't needed and the materials are needed, but because COVID hits populations so unevenly, it has to be looked at bottom up as well. So I'm now turning it over to Bhumika, Nanda and Shiv Kumar first from the COVID Action Collab in India for them to share their experience. They're long-standing practitioners when it comes to public health, and they rallied to COVID-19 and their networks very, very quickly. What is it that you did? Can you please share those experiences, right? We're greatly worried about what's happening in India and very eager to hear what you are seeing on the front lines.
Thank you, Fredrik, and thanks everyone in the panel and those of you who are investing time listening and participating in this discussion. I'll probably ask Bhumika to kick us off, and then I will come in. Over to you, Bhumika.
Thank you so much, Fredrik, for the introduction. Thank you, Shiv, for letting me speak right now. First of all, good morning, everyone. My name is Bhumika. I work with the COVID Action Collaborative. I work as a public health specialist. I have been working with the collaborative for over a year, and that's around the time that we started conceptualizing and thinking about the COVID Action Collaborative sometime in March of last year. Just taking from something Fredrik was saying right now about how the focus has been on the supply side and very little on the demand side. The Catalyst Group as an organization, we are a 25-year-old organization, and Swasti, one of our sister organizations, we've been working extensively with marginalized and vulnerable communities ever since, and people-centric approach is the principle that we follow in almost all of our work and projects. And so when we already had the experience of having worked with vulnerable communities over the years, as well as working in humanitarian crises that has happened in India over the years, like the Kaja cyclone. And from there, we had certain experiences in disaster management, in working with communities and bringing our best of expertise to the ground. I think that is how we thought of the COVID Action Collaborative. And one main reason was that we realized that with a crisis this big and this huge, which has deep impact, the network also needs to be wide, and the impact also needs to be really deep. And this gives us an excellent opportunity to be more resilient and be prepared for the future, while supporting the existing resources and the communities that we work with interventions. And that is how we actually came up with this collaborative. So I really wanted to take this opportunity to share that with you, because I'm really proud of having worked and providing real deep impact and really thinking about people at all times. The way we actually, the strategic framework or the theory of change for our collaborative, sorry, just give me a minute.
I have the framework on the screen. You're able to see it?
Yeah, so I wasn't able to see it. I can see it now.
Okay.
I can see it now. So if you can see our framework, we have kept the people in the center, and it's just not for the diagram. Like I said, in our thinking, it was the people that we began thinking with. And what we wanted to get and where we wanted to go with these interventions was resilient and thriving vulnerable communities who would be efficient and effective in providing these the framework for these communities to, and institutions for these communities to be built in, and our response towards them should be dynamic, humanitarian, and build an ecosystem of resilience and thriving. So that is what we aimed at, and the way we wanted to do it through the collaborative, which is actually we have over 300 partners right now in this network, be through calibrated services, which would be specific customized interventions that were built specifically for one or more of these vulnerable communities, and provide a platform for solutions to be exchanged, since the problems are so unique and complex. We wanted to bring in multi-sectoral partners to be able to exchange these solutions, and impact canvas is when ideas are exchanged and we think about different ways in which we can reach these people and help them and support them. So we work in 4 domains across the country right now: health, livelihood, social protection, and food and relief securities. And the kind of partners that we have, that we help deliver these services through, implementers, as in the people that work extensively on the ground and have good experience outreach, and we help them deliver that more efficiently. Providers of material relief, human resources, and even volunteers and HR support who help provide and facilitate the implementers on the ground. And lastly, enablers, and these are people from the policy space, people from institutions, academia, who help bring all these together and give us the evidence to back our interventions and help sort of close the loop with all of these. So this is how we do it, and the technical support that the collaborator provides is with the training, providing and raising finances for our partner organizations, building their capacities for them to be more resilient, and constructing and building on infrastructure. That's it. I would like to, Shiv, can we go to the next slide, please?
On the next slide.
Thank you. So the vulnerable communities that we have focused on in the past, and we've added a little more as the collaborator began to grow, were victims of gender-based violence and child abuse, migrants, gay and transgender people, health workers, domestic helpers, street children, people with disabilities, fisher folk, small farmers, sex workers, informal labor force, school children who are in and out of school, and finally people in homeless shelters and disabled people. Because we realize that these are the people who are always mostly disproportionately affected by the pandemic and are also the last to receive any kind of help and services. So the burden of the entire injustice lies on these communities. That is how the collaborative has been designed. At this point, I would like to hand it over to my colleague Shiv to take us through our work. Thank you.
Thank you, Bhumika. Just to quickly wrap up what Bhumika was saying, we are around 315 partners. We are in all states and union territories in 700 districts through our partners. Currently, we are reaching 3 million, but we would like to reach the 10 million. But even you would agree with me, 10 million is still a very small number in a country like India. We have managed to raise around 20 million USD and put it in the hands of communities, particularly from government and global fund directly into the hands of the community, and 1.7 million services have been delivered. I'm going to jump straight into lessons learned. We, like all collaboratives, have been very quickly built to purpose, but lots of challenges still. I think emergency brings leaders together and melts boundaries, but without mutual value, the energy dissipates in collaboratives like this. So we are constantly talking to our partners. We have a partnership results accelerator team, which speaks at least once a month to each of the partner and then ensures they are participating in 2 or 3 events every month. And therefore, they are able to connect with other partners and with the collaborative as a whole. The second big challenge in India is really the response is very fragmented. Government is doing its own thing, private sector on its own, and civil society on its own. In the past, we have collaborated very well. It's a country which has done very well in the HIV epidemic, but we have not been able to do that. We are still struggling, but still progress is possible, even individually within these groups. And what the collab has been able to do is to at least bring civil society and private sector together. And wherever possible at local government level, we are finding a lot of traction. And we do work very closely with the government. And Fredrik, you did mention about the funding policy changes. We've had enormous deadly blows on the civil society, which is struggling for survival and effectiveness, not only because of the pandemic, but also huge changes in the laws relating to civil society financing in India. You would hear about FCRA changes quite a lot, but there are other changes which are there, which have also led to a lot of civil society funding getting crunched. Vaccine, again, Fredrik, I'll refer to your point. It's not about supply alone. Yes, supply is a big issue, but the most needy, as we found out in polio, would get it the last. Unless we put them in the front of the line, unless we convince them to stand in front of the line and ensure that they get access to it, it's not going to work, right? And the whole social and sector mobilization CAC has done has taken significant efforts and resources, and it has taken a year to do it. We do not want to do this again. And we have done this earlier in tsunami and earthquake. And we have realized that this mobilization of the civil society and the private sector should be protected and as an asset be used for the next catastrophe, whether it's climate-led or health-led. And there's been tremendous lessons learned. I mean, India's story on HIV or polio or TB, where there's a lot of struggle. There's a lot we can learn from, but we are not still doing that. And I believe, India is still in a virus-centric reaction mode, not a people-centric response. But as you can see through the social media and several reports, which filter out of the country is usually negative news. But there are several positive news in terms of people-centric responses. And we believe our collab itself and its partners are in the front line of doing that. And I can explain a little bit more. Fredrik, over to you.
Thank you very much. I'm going to pass it now on to Shona, and we're all going to come back and have another round really looking at those calls to action for the way forward. But Shona, you, as I said earlier on, have devoted your life to issues regarding disability, and with a strong focus on South Africa, but it actually extends beyond that. What have you been doing, and what can you share, please?
Hi, thanks, Fredrik. Yeah, just as a brief introduction to what Shonaquip does, we have a program that really takes a holistic approach to disability, with a focus on think disability, think family. So it's really about building this ecosystem of support around the family of a person with a disability, touching on 4 main pillars, which we believe are fundamental in terms of building a more inclusive and accessible and diverse community. So that those 4 pillars touch on advocacy and lobbying, wheelchair provision and posture support management for the prevention of deformities, early childhood education, and then access to work and empowerment of parents. So part of that work includes the design and manufacture of assistive devices, which are appropriate for rural and remote areas. But none of that, and that's what keeps us financially stable as a hybrid social enterprise, but none of that works if people don't deal with and face and have dialogues around the issues of disability and the separateness that has emerged over hundreds of years of bias and stigma and cultural fear around disability. So in COVID crisis, we started realizing that the parents we work with, and there are 8 million families in South Africa affected by disabilities. So it's quite a large proportion. And then of course our work extends into 7 other surrounding countries. So we're talking about millions and millions of people with disabilities and their families were suddenly cut off from all support services. So no access to health services because the rehab centers were closed and it was too dangerous to approach hospitals. No public transport because that again was stopped during lockdown. People couldn't access transport even if it was accessible. And then of course the fear of using public transport was exacerbated. The next issue that really hit home was schools were closed, and many parents who had children in their schools, and that's only about half of them, the rest are all out of school and unsupported. Those parents have no idea how to educate their children themselves. And it became very clear that disability has become an economic driver and income generating opportunity for professionals. And although the professional knowledge is vital to the progress in the disability sector, holding that separately from the knowledge that parents need to actually be the owners of their own children's disability themselves and be able to make decisions and truly understand what's needed for their child became so blatantly clear that it was life-threatening. We had parents with children with autism, with epilepsy, severe physical and intellectual disabilities, completely lost as to how to care for their children and with nowhere to go. So during this phase, we launched a new program called the Champions of Change, which was geared at identifying parents of children with disabilities and people with disabilities across the country in a very ground up process using WhatsApp and message and really basic door-to-door visits, and connecting these parents with each other and creating a network of support which shares information and data, but also more importantly, provides parents with the opportunity to connect with each other and create a bottom-up approach to information gathering and dissemination. So over the next, I think it took about 3 weeks, we were working already in all 7 provinces. We had hundreds and hundreds of parents already connected to WhatsApp groups. We were running WhatsApp videos, training sessions, and connecting parents with each other. And in this process, we suddenly realized that this would be the most ideal way, not only to disseminate information down and empower parents with knowledge, but to use those parents to monitor the delivery of government policy and the barriers that parents were experiencing in terms of getting delivery on the policy. So this now is growing exponentially. We've built an entire infrastructure around the parent network where we have advisors, we have a board, we then have parent champions who actually transfer the information down. Each of those champions identifies in their village or very close regional center parents door to door who have disabilities, and those people are then connected with each other. And in this way, information is flowing down, but it is also flowing back in a way that we can actually monitor at any time what the major barriers are that people are feeling and experiencing, where the challenges are in the community, in that specific, very centralized community, where language barriers are no longer a problem in terms of training because we're working just in that community with a parent champion, and then bringing all this together and back to government to try and leverage them on what are the actual experiences of those families, what actually are the costs those families are experiencing related to their disability, and how government can be positioned better to address these needs. I think the most interesting research that's come out of this now is the cost of disability that I don't think up until now was able to be measured because we weren't connecting with people in this very personal way before. Thanks.
Shona, thank you so much. Really, it again, just as with Shiv, it showed how fast you were to react and how you, in effect, were able to make out of necessity an opportunity, right? To be able to bring people together. And I hope indeed that lays the groundwork for work that will continue and grow. Sipho, we've had the pleasure of working with you among a number of other partners, and indeed we also engaged with Shona and with Bhumika and Shiv. But Sipho, in Zambia, you've done amazing work engaging with health authorities there across a range of provinces. Can you please share that experience and how they have responded to you, simply taking this initiative, reaching out to them, health workers, officials, how have they reacted and what have you been doing?
Thank you, Fredrik. As open it for all Zambia, I think we have not, as a country to begin with, I think we've not been exempted from the effects of the pandemic. And one of the open it for all Zambia, maybe just to share a little bit about what we do as an organization so that everyone can know. So OpenAid for All Zambia is a community-based organization that is based in the southern part of Zambia, in Choma to be specific. And we have offices in all the 10 provinces of Zambia. And really our structures, our structures, everyone that comes to work with us works on a voluntary basis, because we, as a small community-based organization, I think issues to do with funding and all of that, I think those are challenges. But nevertheless, so some of the areas of focus that we look at, we are into governance, health, ICTs, culture, and the environment. So to speak about what we've been doing, and during the pandemic, since we signed with a partnership with TrueFootprint, I think we've been engaging the provincial health office at province level to try to use the app and see how best we can, as advocate for the changes that we want to see within our own health systems, and what are some of the gaps that are there. So through that, we also paid a courtesy call to the permanent secretary in Lusaka, and we were given permission to try to use the app to see how best we can try to advocate for that and try to improve our health system. So we were given permission, and we recruited, I think, about 6 districts that's across Southern Province alone. So we've been working in Southern Province. And one of the issues I think that we've experienced and seen as an organization, I think, to our end, is that there are a lot of gaps within our health systems that needs to be improved, for starters. And in order for us to actually attend to some of these gaps, I think the app really, in my experience and in our experience, I think, together with some of the health workers, I think it has really shown what critical things that we really need, especially that we're hit with the pandemic. It has also showed to us some of the challenges that we were not seeing. So the pandemic, because of the pandemic coming in, our health system has been laid bare, like in open, in terms of what is it that we really need at the moment to improve and to build on our already existing structures, and not to try to take away anything. So we've engaged on a personal level with the medical superintendent at facility level, the district health directors, and also at district level. And at province level, we've tried to engage, and they've been helpful to that end, as we are still pushing in to bring in, to make sure that this is something, a solution that we can use, in terms of pandemics, and also in terms of advocacy to improve our health systems. Now, one of the key issues to share with everyone, as in what we've really seen, is that community engagement is very important, because as we are at right now, I think there hasn't been any kind of adherence, as in to say. I think we are in a state as a country where we are not learning from our mistakes and trying to improve, even though, so to speak, the Ministry of Health is trying to do its level-based to try to sensitize. But we believe to say we have a role to play as an organization in terms of community outreach, because we are based in these communities where these very same people are in. And if we are to build that relationship, people could take up ownership. So there is need to come up also with deliberate engagement of policies or framework, working framework, to improve knowledge sharing, as well as coordination amongst communities, government departments. As you are aware that where we are here in Choma, Choma is just a peri-urban, meaning that we are surrounded with a lot of villages out there. Now, the worry there is, should this resurgency go to an extreme, it means that in places like in rural communities where the health facilities, they only have clinics, and the clinic has only probably 2 or 3 bed spaces. That can be catastrophic on our end, and this is where we have to come in. And I think also the app in itself, I think the way it has been used in our experience, together with those, I'm also speaking on behalf of the health personnel that were using it, and some of the recommendations that they made. To them, it was really a game changer, something that the Ministry of Health could use and try to improve our coordination, because it's able to give real-time data as it occurs in real time. And it's also able to hear, I think one of the experiences shared in one of the districts in Mwanza, I think after 1 week along the pilot, they called me to say, hey, look, I think things are improving here because once they see it on the dashboard, they are really able to respond. So it's able to alert even those that are responsible to supervise and say, hey, look, we don't have this, and this is kind of an emergency. And the times that we're living in are really dangerous times, that are really desperate times, that we really need to come together and put our hands together. But also on issues of services, I think a lot of services have been actually disturbed. When we talk about youth-friendly corners, these are young adolescents that depend upon day-to-day, every weekly visitation to hospitals to access some of the health services that the health facilities are offering. But in line, in the work of the pandemic, a lot of services have been disrupted. It's not only the pandemic, but as well as some of the economical activities. Now, what does this mean for all of us? It means that a very huge chunk of people are thrown back into the communities. Take, for example, in Livingstone, where we are, Livingstone is a tourist capital. A lot of people depend on selling curios and cultural things to sell and on the hospitality industry. So you'd find that a lot of people are laid off because hotels, no one travels anymore. Hotels are closed up, and the effects of that is it goes back to at household level, meaning that the poverty rate has actually gone up, meaning that there's need also for interventions in line with that to make sure that even though such kind of things are happening, we're able to build back better by also adhering to some of the public health guidelines that have been put for us, but as well as involving the community. I think this is one thing I've seen that we are not doing as a country. I think there is need to improve on how we engage the communities, because they are also stakeholders, and we really need to start identifying them as such, not only as beneficiaries alone. I think that has been the mistake that I've seen, and this is something that we can learn from. Thank you, Fredrik.
Sipho, thank you so much. And these are powerful concluding words from you, right? So on the one hand, extremely positive to see how open health workers, administrators, and public officials in health were actually to engage in this way. And everything that you're describing is all about self-advocacy, right? And this is a theme that I'm hearing across the presentations so far. So they are not averse to this, right? And yet it really could be so much deeper in terms of the community engagement. And we've seen that vaccine hesitancy was very high, for example, in Malawi. It led to them having to throw out thousands of doses of AstraZeneca vaccines. In South Africa, hesitancy has been high, and unfortunately, misinformation was spread from high on among political leaders and even judicial leaders. And then you see the disaster of Congo DRC, having to return over 1 million doses, have to be passed on to other countries because they just don't have the infrastructure to deliver. And who knows where the rates of hesitancy are there as well. Andreas, it's a pleasure to conclude with you in just this first round of the panel. We've known each other for a few years. You are, I don't want to say that you are old, but you have many years of experience with public health, right? And you have managed programs of the Global Fund in a number of countries over the years, including in India. And now you look at digital health issues. But so the question of a people-centered approach is, and having key affected populations be really at the center of any lasting and resilient solution, that's core to what the Global Fund does. And I'm not singling out the Global Fund at all here, because the Global Fund deals with these 3 disease burdens of HIV, AIDS, TB, malaria. It doesn't deal with COVID. That's not in your job description. But what it seems to us here on the panel, and from the work that we have done with the COVID Care Monitoring Coalition with partners by now in 67 countries, is how difficult it is to bring home the message of this people-centered, key affected population-centered approach. Why is this so difficult, Andreas? Why does it seem that we're having to relearn these lessons? And then if you have any reactions to what the others have shared, that would be very welcome as well. You're on mute.
Thanks, Fredrik. Sorry, I am on mute and my dog just came in, so we're all settled here in our work from home environment. I came into public health at the end of the Cold War when I started working for Johns Hopkins University in the area of maternal and child health, and I found myself, ironically, in the late 90s and early 2000s in Central Asia, battling issues such as access to basic healthcare, anemia prevention, nutrition, and other issues of child survival. This is in a context of countries with health systems that were basically suffering financial constraints and a loss of professionals who simply couldn't make ends meet on very basic salaries. These problems aren't unique to Central Asia, but they're characteristic of many settings where a lack of money, a lack of resources, a lack of support leads to a slow and maybe not so slow disintegration of basic health systems and basic health services. Countries tend to focus on this disintegration, this systemic disintegration, and individual client and patient needs and community needs sort of take a back seat when people are scrambling to either maintain what they have or reconstruct what they've lost. And I noticed over the course of my public health career that it's one thing to look at funding flows. And let's see if I can share. Can I share a screen with you guys? I'm usually on Teams, so I'm not sure that I can.
Marina, can you make Andreas host?
And yes, I'm on it. Yeah.
And what do I hit here?
Now you'll be able to do that. You can click on share screen in the bottom.
Oh, yes. Here we go. And I just wanted to show you, if you can see the screen here, this is a funding level view of a country program, in this particular case, India, but it could apply to any country in the world. If you take any funder that is responsible for investing resources in country health programs, they will tend to take a view similar to this. I can make it a little bit bigger, probably just to give you an idea of what this is about. What you're looking at really is a division of roughly $1 billion over 7 grants signed with India, with different organizations that are divided into health products, the commoditized portion of the grants, program activities, and program management costs. When a funder, such as the Global Fund, looks at how investments are divided, they look at the original intent for the use of funds and the expected outcomes of those funds. So this is a fairly typical division in which a lot of money goes to drugs and other health products, including personal protective equipment. A lot of money goes to what we call results, i.e. measurable changes on the ground. And a fair amount goes to the people who need to effect those changes. Now, if you look at the diagram a little bit more closely, living support to clients and target groups is a fairly small proportion of the overall picture. Human resources is a fairly small proportion of the overall picture. Results and health products are really the focus of most of the efforts. In other words, the mission from a donor perspective is to get medicine to people and to make sure that results are achieved. And this is where I think communities and clients and patients can really, really make a huge difference, not only in terms of how money is spent, but what it achieves. when communities are involved, when people know what they should be getting and can tell the people who are providing what they should be getting, whether they're getting them or not, it can make a huge and key difference in whether a program, quote unquote, achieves its results or not. But that loop must be very, very tight and as real time as possible. And this is where I think that an approach like TrueFootprints can really be a game changer. You guys probably know that the Global Fund recently received a commitment from the US government for another $4 billion additional US dollars for what we've called our COVID-19 response mechanism. And basically, it involves not vaccine procurement, but 6 system strengthening activities, if you still see my screen, including social mobilization with the express purpose of addressing testing, treatment, and vaccine hesitancy. It includes infection prevention control mechanisms. Again, this is not just health workers. This requires knowledgeable patients. It involves reaching people who are hard to reach. Of course, it involves some simulations as to how to reach people with vaccines. Surveillance and monitoring frameworks, we all love those. And how to adapt existing health information systems to the COVID crisis, and anything else. You don't have to memorize this, just know that there is a lot of funding out there that is looking for mechanisms, approaches, and involvement of people that can create lasting and catalytic change. The challenge for donors right now is as simple as finding the right approach in the right context, be it Zambia, be it India, be it Central Asia, to measurably turn the corner on COVID and to preserve the gains against the 3 diseases. I mean, that's the Global Fund speaking. But you can put yourself into the position of any donor who is basically looking at, I lost my other, who is looking at the types of monies that they've put into public health activities across the globe, and imagine what they would consider to be an outcome. Now, that's from a donor perspective. That may not be relevant from a patient, client, or community perspective. The challenge for the community is to make what's relevant and what's most important to them a good candidate for funding, not only from international donors, but from national agencies. I also read in the paper today that the Indian government is, if I understand it correctly, quote, making 6.7 or 6.8 billion US dollars available to address the COVID crisis in India right now. That sounds great, but the devil is in the details. And the details are what will make the case ultimately for community involvement and tight feedback loops. So I'm very, very happy that we're having this discussion, and I'm very, very happy that people are thinking about how to, I'll stop sharing a screen, it's so impersonal, how to make real change, real time, that can benefit communities and individuals, and making bureaucrats' lives easier so they can report results in their results frameworks. So that's basically all I have to say.
Andreas, you've said a lot, actually. It seems to me you've given us a roadmap in so many ways. And so, yeah, the will and interest, the call, right, to action is there on our side, but you are telling us that there actually is a potential roadmap for turning this into
in a word, yes. I mean, if you think that people, you know, a few hundred people in Geneva know immediately what to do with $4 billion that's just fallen on their heads, I mean, come on, guys, we need to think about this. And I think the whole world needs to think about this. $4 billion sounds like a lot, but you know, if you divide it across the globe, it isn't that much money. It really isn't. There's a much more need out there than there is money to address it. And when the need is recognized, the resources will be there.
Well, that's a powerful point as well, Andreas. Thanks. I mean, this is one occasion where indeed the world has to an extent rallied together. And even though indeed the rates of vaccination in low middle income countries compared to what's happening in some rich countries is again absolutely disproportionate, but nonetheless, there is a realization that this is not tenable. It's simply not tenable. So it is perfectly understandable that countries have prioritized their own citizens. It's very difficult to argue otherwise. But of course, it cannot be like this. And that's why the Biden administration has made the pronouncement it has. That's why it's providing all this funding to the Global Fund, and others are as well. Shall we do a quick round? Yeah, we have shared these wonderful experiences. I also want to give a chance for the participants on this call to contribute a bit as well. But if I turn it back to you, Bhumika and Shiv, your initial reflections, what would you highlight as calls to action in the context we're living now, and anything that takes us into creating an infrastructure, a set of policies that help us going forward as well?
Bhumika, shall I? Please come in. No, I think it's fascinating, and I think the conversation, Fredrik, moved from Shona's work on a priority community and what you can and should do with them, and what Sipho was sharing about how do you build on the assets on the ground and programs which work. And Andreas, your analysis of the funds flow, and you know, there is the money, there is the intention, where is it actually going, right? I think to me, I just want to pick on what Andreas was saying. Of the $4 billion, 150 million was allotted to India. Out of the 150 million, we decided to purchase PPEs for 75 million. The people are still forgotten. And I have been you know, pleading, begging, persuading, and doing whatever in my powers along with the collab powers to say, where is the people in this? What is the interventions? What is the priority that we are actually putting out there? So my single call to action would be, how much of our response to COVID is people-centered? And I think that needs a little bit of unpacking also, Fredrik, because it's, you know, everybody can say, well, what else are we doing other than people-centered, right? I'm buying PPEs to protect health workers or this thing. So I think to me, you know, people-centered means prioritizing the most vulnerable. Secondly, listening to them with tools like TrueFootprint and other tools, right? Listening carefully, what's coming from the ground up. Thirdly, work with people's institutions. There are quite a few in every country which has been built, and we work with and through them. And then we also need to ensure that they can control resources during this period, whether it's stocks of vaccines or oxygen or access to beds, right? That is very, very important. We had the Mumbai commissioner speak yesterday. It was a sterling interview. It's a very long 1-hour interview. But what he said there was really amazing. He said the poorest people in Mumbai, in the slums of Mumbai, have been the most organized. They have not been tweeting and asking for beds and jumping up into a car and landing up in a hospital. They have followed all the protocols that government had laid out. And therefore, the positivity rate in some of the most crowded slums is much lower than any other part of India. What are we learning there? Right? There was a people-centered approach in one of the most crowded slums in Mumbai. So all I would say is the call of action should be, is our response really focused around people and their requirements? while we talk about the larger pharma and this thing, I think, Andreas, that is where a certain percentage being allotted to people-centered response has been something community system strengthening approaches have kind of advocated for. But I still see that missing in the current response even now. I'm not talking only about Global Fund, even what Indian government is going to set aside $6.4 billion. How much of that is actually going to go down to the to people-centered response? So to me, that would be the key thing, Fredrik.
Thank you so much. In fact, had we had this meeting at another time of the day, we would have invited some Brazilians to join us. And you know about the G8, you know about the G20, but you may not have heard of the G15, which are the 15 biggest slums in Brazil. And the executive director of that movement, Secretary General, whatever he is called, they did such an extraordinary jobs indeed in the favelas of Brazil that their infection rate was about 1/3 of what it was in the metropolitan areas. So exactly the same. Right? And it is all about the self-organizing that took place there.
Just like
Shona.
to add.
Yes, please, Bhumika, sorry.
Just adding to what you said, I really, I also take in the call of actions as to listening round up and keeping the channel also open. I would just like to add that, while we spoke about demand and how it's important to see what is the demand side of it, I believe that even as a collaborator, when we started working, we have a single view of the demand at one point, but the demand keeps changing, and it has changed so much over the past years, and making that effort to continuously do that, continuously keeping an eye out for the evolving demands, for the evolving situations on the ground, and being that dynamic to be able to respond to it at the given point is also something that I take in from this conversation.
Well, I mean, you put that beautifully, Bhumika. Thank you so much. And this is to Andreas's point. It has to be as tight as possible, as real-time as possible, as granular as possible. As Shona was saying, it's about that specific community, right? That's what it's all about, indeed. It's not about the general need. The general need is very well recognized. It's about those bottlenecks and those specific problems that occur. Shona, calls to action, please.
Yes, so I wanted to mention a few points, and one of them, I think, which is I'm experiencing as a huge barrier to scaling our work, is the way that we are measuring the outcomes of work. So when corporates want to get product to people, they're measuring a specific thing. It's the amount of product that has got to people. When government is measuring, they also measuring the sort of like the actual end result of getting stuff to people. How many people are inoculated? How many people are complying with wearing their masks and distancing? It's really about the action. I'm struggling with the need to measure the real outcome, the effect that it has, that the product actually has on the person, and not the medical, necessarily the medical outcome in that what were the reactions to the vaccine, or what number of people did or didn't get COVID, but what is the actual impact on the family's life, on the person's life, on their ability to actually have a quality of life which is meaningful. And I think where I'm stuck is the same is happening with funders. Funders come with their own set criteria of how they want the outcomes of interventions measured. What we are not doing is engaging with those end users, with the people that we're actually trying to help, and asking them what is meaningful for them for us to measure. What would be an indicator for them of an effective intervention? And then using that information to bring it back up the line and use it to influence policy change or delivery change or funding change. And I think it is this disconnect of language and what we want to measure and prove that is really the barrier to progress and scaling what we're trying to do. So I think from our perspective as an organization, the measuring of impact has become and has been for many, many years, we've been going over 35 years, that measuring of impact is the most vital thing that we can do. But the measuring must be done by the people we're working with and not by us in terms of laying down the rules of engagement. So I just wanted to bring that up because I'm very interested to connect with funders who are wanting to explore different ways of measuring and delivering on the funding that they provide, ways that truly are meaningful to the people we are really working to help, and not to the economies that support the funding or the government or the actions, because it's those economies which are influencing, I believe, the incorrect reporting and measuring of impact.
And Shona, just to round this, because this is such an important point you have raised, can you give any examples of what you have experienced people highlighting as being what they consider meaningful?
I suppose, yeah, so many. I'm just trying to think of one that's relevant. But for example, we got funding to work in a specific area in South Africa to do door-to-door surveys and actually work with parents to understand the number of children and youth with disabilities in that area. I think it was a 21,000 household survey. Then we used that survey to actually raise funding to go and do interventions. But because we, like Shiv, work with government, we needed permission from the government to do that intervention in that area. Government wouldn't give us permission because they actually didn't want to know how many people there were there, because if they really knew how many people were there, they'd have to increase their budget for that deliverable pillar. And so we ended up having to do work elsewhere when actually that region was the one that really needed the intervention. And I mean, I really feel for government officials who are overwhelmed with what they need to be doing right now anyway. And now we're coming in telling them actually your 100,000 is actually a 55,000, you know, they panic. So, but I think what is really important is that we get on the ground and we listen and we connect in a human way and stop trying to satisfy the economics of the program from the top down, rather drive it from the bottom up and be responsible